the outset, I would like to thank Amulya Sahu sir and Jagannath Boramani sir for giving me this opportunity time and again. I think this is like the fourth time we're presenting this together, sir, in this session. So, I, being a cornea surgeon, I would be, more interested in correcting the astigmatism, being a refractive surgeon. So, SICS can also be as good as phacoemulsification if we take care of the astigmatism part. So, because the patient also expects SICS, and we as surgeons also want to give patient the best possible vision. So, this is just, I'll just run through the astigmatism. So, we have something called the regular and the irregular astigmatism, and we all know what is regular, and in the regular we have the against the rule and with the rule astigmatism, and again we have the irregular astigmatism where we can have the oblique astigmatism. So how do we manage this? So why the initial part was important is because we should place the tunnel accordingly. So that's why we have to know where the astigmatism is more. So how can we induce astigmatism in patients when doing surgeries? By doing cautery in the wrong way, by not placing the incision in the right way, by modifying the suture characteristics, and also post-operative factors like not using steroids correctly. So pre-existing astigmatism, again, the final astigmatic error largely depends on where your pre-operative astigmatism is. So wherever your corneas are steep, place your incision in that meridian. And cautery, so whenever you do a cautery, make sure you use a bipolar cautery, wet field cautery, and cauterize only the bleeders and avoid the blue zone. If you're going to cauterize without removing the tenons, you're going to end up charring the tenons, and that is going to lead to irregular corneal wound. So make sure that you remove the tenons completely and then cauterize, and use a wet field bipolar cautery preferably. And excessive cautery again can cause scleral necrosis, which can again alter the outcomes of your incision. And never do a cautery after you've done the incision. It should always be done before doing the incision, because if you're going to do your cautery after you've done your incision and your tunnel, you're definitely going to cause fish mouthing, which is again, your wound will not oppose well, and you're going to have issues. And again, the incision characteristics, again, you have to think of the location, where to place your location, what length, and the configuration of the wound. So location, as I already mentioned, we will place it at the steepest meridian. And the external configuration and internal configuration to a wound. So external configuration, this is the pointer. So, can I? Yeah. So this is the arc length. So when you start from this end and goes along the line of the incision, that's the arc length. And from the point of initiation to the point where it ends, so this is going to be your cord length. So this is very important. So Dr. Manisha made my job very easy by saying that the frown or the chevron incision is the best, because she mentioned rightly about the incisional funnel. So that's a funnel that is an imaginary line, which actually, when you draw two lines away from your cornea, from the limbus, away towards the scleral side, and your tunnel falls within that range, then you're going to have good outcomes. So that's why the frown or the chevron incision is best, because here the arc length is huge, and the cord length, that is this point, is again short, and it is also far away from the limbus. So always ensure that you start your tunnel at least 2 millimeters away from the blue zone. That's where you have to initiate your tunnel. So your external configuration, it's always good to go. I prefer doing the frown incision, unlike Dr. Manisha, who prefers doing the chevron. So you see this. I've not touched the bleeders at the blue zone. You can just avoid that. And always make a smooth incision. And if your scleral depth is going to be too deep, you're going to end up with a lot of vitreous and unwanted things coming out of the eye. And if it's going to be too superficial, you'll definitely have a buttonhole, or you might have a tear of the incision, which is again going to affect your astigmatism, and it's going to affect your final outcomes. So, it has to be very smooth and gentle movements, and you see the pockets that I'm making, and the final configuration should be a squarish configuration. So that's very important. So you can see this is how my tunnel is. So it's a square like configuration here. So again, internal configuration, it has to be only 1.5 to 2 millimeters anterior. When you have to dip and enter. I'm sorry. You have to dip and enter, and your edges also have to be very smooth. And when you dip and enter, you should not have saw-like movements. You know, when you go up and down, then you're going to definitely cause ragged edges internally. And at the limbal region, it's going to be very tough. So you have to enter slightly anterior to the limbal region. So the length of the wound is directly proportional. I mean, it's 3 times proportional to the astigmatism. So that is why we spoke about the chord length and the arc length. So this is the imaginary tunnel that we were discussing about. So again, suture, when you place, don't shy away and don't, refuse to put a suture. When needed, you always have to do it, especially when you have a complication or if you feel your wound integrity is not good, never shy away and always make sure to close the incision well. So when you have to place sutures, which is a rare thing, if your tunnel is good, your wound integrity is going to be maintained in SICS. When you have to place it, always make sure that your sutures, one suture would usually suffice, but in case you've extended beyond what you had planned initially, then in those cases you might have to suture it. So when you suture more than one suture, make sure the suture lengths are equidistant and also the lengths are equal. That way you will not be inducing astigmatism. So here you see when your length is more than the width, then you will be inducing with the rule astigmatism. And again, when your sutures are widely placed, you're going to have against the rule astigmatism. And tight sutures will definitely cause with the rule astigmatism or depending on where your location is. Loose sutures, again, your sutures will not oppose properly and it's not going to. So this is how the suture will cause an effect when it is too tight. So I think want of time. Yeah, so in case you want to, post-surgery, you want to correct a patient with astigmatism, obviously suture, you have to remove the suture at least 2 to 3 months post-surgery. And spectacle correction, contact lens and LASIK surgery is an option, but I don't do it. Yeah, thank you very much.
Yeah.
Thank you, doctor, for the wonderful talk.
Divya, you have opportunity for research. I think you should give little time for this. The suture is becoming obsolete, sort of.
No, no, but yeah, but when needed, it should really be used. So I will beg to differ from sir. It's not obsolete. Seat belt and parachute is needed sometimes.
If you tell the students, they have that inhibition that I have to give the
Dr. Boramani sir.
Anyway,
Sir.
Because ours is a training institute, sir. For the first 50 cases, we ask all the students to suture it.
I will next time expect a research paper from you. Okay, thank you.
We have discussed on writing for the suture. One of my senior residents came across this. A lot of PGs were making straight, long incisions a little close to the limbus, and we were not happy with that. So a single suture placed just right, like you're saying, neither too tight nor too loose, has led to 0.5. That, and we have analyzed those cases. I am comparing with Chevron and published to this.
Yeah.
We have discussed in the group.
No, you people are teachers, so some research is expected. Okay, thank you.
Suturing is a dying technique. Like when I don't know, our residents have problems. If you ask them to, if they are supposed to suddenly suture something, they take hours at a stretch. So it's not like.
Okay, our next speaker.